he wants.
I think he doesn't do
If
that
I
early.
can
So,
enjoy.
welcome everyone, and happy almost holidays. Okay, Shane, what do you see?
Focused here. See red and white.
Actually, no, before you focus, because the poor people online are way out. Let's get that first. Okay, now everyone get yourselves back in.
There's face reedies pallor at the dermis. The deep, it looks pretty sclerotic though, and then maybe some trapping of the eccrine at the bottom, so like a morphia maybe.
Yeah, so it looks like morphia. You pointed out at scan that you have loss of space between collagen bundles. I think I heard that. And loss of periadnexal fat, so-called trapping of the eccrine glands, smudging of the collagen. You also pointed out the homogenization and pallor of the superficial dermis, which looks just like lichen sclerosis. So how would morphia with pallor in the papillary dermis differ from lichen sclerosis?
It doesn't have the vascular interface with the vein like this.
So it lacks both the vascular interface dermatitis and because of that also the pigment incontinence that goes with that. And it completely lacks the sparse lymphoid band that is typical of lichen sclerosis. So very good. So true LS always has a lymphoid band. Morphia that mimics LS lacks the lymphoid band. How about radiation dermatitis? How would that differ?
It doesn't have the band either, but it has diet. This one has sort of deep radiation kind of homogenization of collagen.
So radiation dermatitis, just like morphia, lacks the lymphoid band, has ectatic irregular vascular spaces, which this example of morphia doesn't have, has radiation elastosis that looks like solar elastosis except that it involves the fibrous tracts of the hair follicle, and has radiation fibroblasts, but lacks all adnexal structures because they've been fried, so they're gone. Okay, very good. Good discussion. As low as we get, so here's your epidermis way up there.
So it looks like we have a really thick punch.
Hell of a trachea.
So where is the pathology?
Down very deep.
And by the way, there is no organ of the body that cannot be reached with a 4mm punch and a good strong arm. But okay, so this is nice and deep. And where does the pathology reside?
In this area.
Yeah, in this area, which would be, so we've already been through the sub-Q.
Yes.
So kind of where,
Some kind of muscle.
yeah,
Between
so
the fat and the muscle.
yeah, between the fat and the muscle. So what envelops the muscle that might be thickened here? The fibrous tissue on the outside of the muscle.
Would this be the eosinophilic fascia?
Yeah, so this is a massively thickened fascia. So if it's eosinophilic fasciitis, where are the eos?
Peripheral.
Yeah, very good. So the eosinophils are two places, in the peripheral blood and in the name, but not in the tissue. They can be, but rarely. So eosinophilic fasciitis named for peripheral eosinophilia. The other thing that this can be, though, is morphia profunda. Morphia profunda also involves the fascia and deep septae. This has nodular lymphoid infiltrates, probably lymphoplasmacytic if you look closer. It certainly has smudging of collagen. So this could be Morphia Profunda or could be eosinophilic fasciitis. Clinically, the easiest way to tell them apart is to pinch the skin. In Morphia Profunda, the skin itself is rigid. In eosinophilic fasciitis, even though the arm is hard, the skin can be pinched on the surface because the sclerosis does not extend up through the skin. Difference in therapy is eosinophilic fasciitis requires corticosteroids, Morphia Profunda requires methotrexate. So, they'd be treated differently. And the other thing that can help histologically is do a CD34, completely gone in all stages of morphia to include Morphia Profunda, usually retained in most other sclerosing conditions, including eosinophilic fasciitis.
Dr. Elston, why is there a groove sign?
The groove sign is because the sclerosis is in the fascia and septi. The vessels are in the septi, and so they get drawn down they get tugged downward by that sclerosis. So, okay. How about this one?
So you have some skeletal muscle here.
Skeletal muscle.
You thicken fascia.
A thickened fascia and lymphoplasma. This all looks so familiar.
Yes, it does.
In this case, where does the sclerosis end, or does it continue?
It continues above the sub-Q.
Which does that suggest?
Morphia Profunda.
Exactly. So this one you can tell for sure. You can tell that this one's morphia because it continues right up to the surface. Whereas eosinophilic fasciitis only lives in the fascia. So sometimes you have a differential and sometimes it's tipped its hand. Like that one you could just call. So something totally different, usually not in this chapter. Here it is. Rob, you're a second year. You've been through everything. You know everything. So it shouldn't be a challenge.
Looks like maybe some acanthosis. And then deeper, there's kind of a parallel band of, I'm not sure exactly what's going on.
Yeah, so we've got skin with very delicate adnexal structures. So somewhere probably on the head and neck. And then you've got, what is this stuff?
Yeah, cartilage.
Cartilage. How happy is the cartilage?
Doesn't look very happy.
And so what's going on with the cartilage?
So is it kind of almost necrotic?
Yeah. Necrotic and on two sides of a blood-filled space.
I thought about like chondrodermatitis, but I don't know. I don't see the other changes that you would see.
Yeah, in chondrodermatitis, the one thing it usually doesn't affect is the cartilage. Right. It's decubitus ulcer sitting on top of the cartilage.
Right.
So anyone? Pseudocyst of the auricle. Yeah. Cauliflower ear. Someone punched you in boxing, or more likely your sister hit you upside the head, right? James, I'm sure you can relate to that.
Oh yeah.
Okay.
Slap.
Colloid milium.
Colloid milium. Why colloid milium?
Because there's a lot like that. I mean, there's the broken up like the.
So large fissured amphiphilic masses. Large fissured amphiphilic masses, and you can see transition between the amyloid-like colloid material and the elastic fibers. So elastic fibers which change color and become larger and smudgy and gradually transition into that colloid material.
Can you speak about how lipoid proteinosis would look compared to this?
Lipoid proteinosis doesn't arise from the elastic fibers. So you don't have transition
But it's still
of the elastic fibers. You have large chunks that can have some fissuring, but more likely have vertical streaking, vertical orientation. And deeper, you can see that it is the basement membrane zone of adnexal structures and vessels that's massively reduplicated.
The nodular elastosis, same thing as called. Or
Nodular elastosis and
Colored.
colored milium are on a continuum.
Continue. Okay.
Yeah.
It's basically collagen 4, right? In liquid proteinosis.
Correct. Liquid proteinosis is type 4 collagen basement membrane zone that is wrapped again and again and again and again in a million wraps. Okay, James.
This looks like an ulcer. Potentially, well, no, yeah. Look at that extrudiform pattern there.
So you have an extrudiform pattern, and what is being extrudified?
So, I think, I guess EPS, but I wanted to, maybe collagen.
So more likely they look like collagen
Yeah,
bundles
that's what I
and
just wanted it
elastic.
to be the pink.
Yeah.
The
So first off, EPS is a narrow serpiginous path through the epidermis, whereas this is a broad path like you see in reactive perforating collagen. In EPS, it's clearly altered elastic fibers being extruded. In this case, you can see it's striated collagen bundles with a vertical orientation being extruded. So what's the most common setting for reactive perforating collagen?
So I guess it depends on like which things you include. If it's just like the normal one, you include it as the same thing, like renal failure.
Yeah. So
Some people, I've heard
there are
confusing
inheriting.
mincing of this.
So you are correct that it's often confusing the way it's presented. You have a rare inherited syndrome of reactive perforating collagen that's familial. And then you have the much more common perforating disorder of renal failure, which
Do you consider
usually
Curly's
looks
like a synonymous term for that, or is that
and
different?
Curly's is follicular and extrafollicular, and absolutely is the perforating disorder of renal failure. It's just another manifestation of perforating.
Dr. May's got mad.
Oh, really?
Yeah.
No, I think that's all a hodgepodge, and most of it is renal failure.
Excellent.
And it was a Frenchman, not the guy who worked with Mo and Shep.
So there's a flattened epidermis, and there's a little bit of vacuolar interface, and infiltrate that's pushed down, so I'm thinking LSC. I'm sorry, LSNA.
LSNA.
What's wrong with him?
So you beautifully described the flattened atrophic epidermis, which is the A part. We often say lichen sclerosis because sometimes it's hypertrophicus instead of atrophicus, but this one's nicely atrophic. So flat atrophic epidermis, vacuolar interface, smudged, superficial dermal collagen, sparse lymphoid band. Lacks the dilated vessels of radiation dermatitis, lacks the radiation elastosis, lacks the radiation fibroblasts. This one, it's kind of hard to tell. You don't see any adnexal structures, so you don't really know if those are retained or not.
There's a fair amount of smooth muscle.
There's smooth muscle, but it's probably genital
Yeah.
smooth muscle in this case rather than orphan director pili
Right.
muscles. Okay, let's see what else we have here. Let's see. This one. Okay, Rachel, what do you see?
I see a lot of calcified stuff.
A lot of calcified stuff. And is it staying in the dermis, or is it starting to work its way through the epidermis?
It mostly looks, well, I guess there's areas where it's working up through that.
Yeah. So you have transepidermal elimination. So you have pseudoepitheliomatous hyperplasia, and it's a perforating disorder where you have calcium spitting out So how would you refer to a subepidermal calcified nodule? What name would you give it? It's subepidermal calcified nodule. It is. You see it in basically two settings. One is where the heel stick was for PKU, and that's sort of a dystrophic calcification. But the far more common thing is a kid who is 8 to 12 years old on the chin, and this thing starts spitting out through his chin. So it's almost always a young kid. They're always about 8 to 12. Most of the ones I've seen were smack in the middle, 10 years old, with this thing coming out of their chin and spitting little granules. You know, why it occurs like that on the chin, who knows?
Pavement
I'm sorry?
or pavement.
Oh, hit the pavement? Could be.
So like
Okay, so this is a PAS stain done, and it shows some focal candida. So the sole cause of this itchy vulva is tinea or candidiasis. True or false?
False.
False. Why false? Because we see hyperkeratosis, which could go with the candida. We see effacement of the reedy pattern, which probably wouldn't go with candida. We have vacuolar interface, we have smudging of the superficial dermis, pigment incontinence, and a sparse lymphoid band. So this person has probably been using lots of creams and corticosteroids and things for treatment of their lichen sclerosis, and then got colonized with candida or tinea. Could be either one. Not uncommon. You'll see fungus on top of lupus. You'll see fungus on top of LSNA. Almost anything that someone is treating with corticosteroid chronically can become secondarily infected with fungus, and you got to treat both conditions. So that concurrence, that kind of twofer, is pretty common.
Okay. So down in the dermis, there is quite a bit of collagen material. It goes pretty deep. I would think that there's definitely a busy-looking dermis superficially as well.
Yeah, there's a little bit of a busy dermis, a little acanthosis. And then what part of the collagen is abnormal, top or bottom?
I would say at the bottom where there's less space between the collagen bundles.
So at the bottom is where the collagen's abnormal.
Mm-hmm.
And tell me about your fibroblasts.
I think they have that stellate look.
Yeah, kind of big, gray, stellate.
Mm-hmm. So this... would this be...
So the big stellate fibroblasts, atypical looking fibroblasts, go with radiation.
Okay, radiation.
So radiation fibroblasts. Radiation dermatitis can be superficial and mimic lichen sclerosis, but with telangiectasia, without the lymphoid band, or it can be deeper. We'll see it after radiation for breast cancer, but probably the most common radiation dermatitis we see is a round circle just off midline on the back. And what causes that? Yeah, someone who's had prolonged fluoroscopy, basically a cardiac cath that took a long, long time, because they're looking from all different directions at the chest, and it all converges on one point on the back. So that round burn of radiation dermatitis just off midline in the back is the most common one we see, and it's someone who a year or two ago had a big, long fluoroscopy procedure.
And I said for scleromyxedema, one of those start either at the top or the bottom, like with the...
Scleromyx is always upper third. And hypercellular. It was the hypercellular part that got you thinking
Right.
scleromics. Yeah.
This one kind of looks like a collared milium, just the way that it looks fissured material.
Big fissured material, elastosis, and a transition between the elastosis and the eosinophilic fissured material. Very good. Collared milium.
Got a big piece of tissue here. Dermis is definitely thickened and kind of hyalinized, acellular. Let's see. I mean, there's still adnexal structures there. So, thinking like morphia.
I don't really see loss of space between the collagen bundles.
Sure.
In fact, I don't see that much, except there definitely is some.
Ectatic vessels there.
Yeah.
So I guess the sebaceous glands are just kind of lost or retained, right? So maybe chronic radiation dermatitis.
Well, you have retained sebaceous, and they'd usually be lost. So we have
Okay.
dilatation of vessels, but retention of the sebaceous. Maybe a little bit of increased space deep. Not seeing a whole lot of pathology besides that and the ectasia. So it'll be interesting to see what the history on this one is. Sclerodema. Yeah,
Okay.
sclerodema. So, that little bit of fenestration between the collagen at the base was the pathology. And the ectasia, I guess, is a red herring in this case. You'd have to match it up with the
So it can be
collagen.
hypocellular in contrast to scleromyxedema.
Scleromyxedema is hyper, looks like too many cells, too much ropey fine collagen in the superficial upper third of the dermis, whereas scleroedema are normal collagen bundles just pushed apart and space in between them.
Looks like a large vessel just rather than the epidermis, I think.
Where do you think you are in the skin?
Acral skin?
Yeah, so acral skin, and it's not so much a vessel as a blob of myxoid material with mucoblasts. So stellate mucoblasts and myxoid, mucinous, snotty material on acral surface. We haven't done it yet. Okay, so upper ear, who knows everything? Yeah, digital mucocyst, digital myxoid cyst. Okay, so let's get something. How about this one?
This looks like ochronosis.
Ochronosis. So ochronosis, named for the color ochre, like in oil paints, not the okra vegetable. So ochre is a mustardy color. So this is an ochre-colored deposition. Ochronosis occurs on altered elastic fiber and occurs exogenous, most commonly as a result of
Hydroquinone.
excessive hydroquinone use. It can also be phenol use. Phenolic germicides are still used by janitors. So janitors who work in hospitals get vitiligo and ochronosis from the phenolic compounds, and hydroquinones would be the more common acquired type, and then the inherited type,
Is alkaptonuria.
alkaptonuria, where your diapers turn dark, and the homogentisic acid.
Not to be confused with alpha.
Starts with L. Aluminum. Alibaba. Don't remember.
Also known as Alibaba syndrome, yes. Okay.
So, looks like a square punch or punch on hair-bearing area.
Yeah, so a little squared off rather than tapered, which is a hint that it may be sclerotic. Does this side look different from that side?
Yes.
Okay, so how does this side look different from that side?
It's a little more pink, darker pink.
Yeah, a little darker pink, a little thicker, collagen bundles a little larger, a little smudgier. These adnexal structures have periadnexal fat. So let's make sure everyone online can see. Sorry about that. I think we got it all in the field here. Okay, so on this side, collagen thicker, smudgier, extends deeper. On this side, collagen smaller, more delicate, periadnexal fat preserved, periadnexal fat half gone, periadnexal fat totally gone as you move into the involved area, suggesting this is what?
So, like Morphia.
Yeah, like Morphia. And if you wanted a confirmatory stain, what could you do?
CD34.
CD34, and that would be accentuated?
Loss of.
Loss of, thank you. I always get that wrong. Okay.
Glad to help.
Well played. Okay.
It's hard to see the orientation of this. It almost looked cup-shaped, but it was very large. So it could be a huge ulcer that's perforating, and those are certainly vertically oriented.
So vertically oriented collagen fibers being spit out through an ulcer suggest?
Perforating collagen.
Yeah, reactive perforating collagen. Very good. Let's see what else we got here.
So you have some sort of amorphous collection in the papillary dermis.
Fissured or not so fissured?
Not so fissured. This was making me wonder more about like lipoproteinosis.
Lipoproteinosis, they tend to be pink or gray.
They're a little more pink than this.
Yeah, this is a little more gray. And in addition to...
So it could be like Fabry-Ricochet.
That's exactly what it is. So what is Fabry-Ricochet?
It's related to sun damage. It's usually kind of on the temporal periorbital. You get kind of like sort of almost like nodular sort of elastosis and comedones.
Yeah, so nodular elastosis with cysts and comedones. The elastosis part is partly due to sun, but the strongest epidemiologic connection is not to sun but to smoking. So they're also called smokers' blackheads or smokers' comedones. They get it, and it looks suspiciously like chloracne because it probably is chloracne from all of the organochlorides in the tobacco. So chloracne, Fabry-Ricochet, smokers' comedones are basically all in a continuum.
Dr. Elston, if those would be seen in the scalp, what would you favor?
If you saw them in the scalp, that's interesting. I would want to know more about the history, but you'd wonder maybe about some toxic exposure.
Okay. Right, because we saw a patient at Wake a while back, and they were thinking Agent Orange, but
Yeah.
the timeline just didn't seem to make a lot of sense.
I mean,
It was interesting.
and they're Agent Orange if you were exposed in Vietnam, but there are lots of organochlorides still used as defoliants in an industry. So the biggest epidemic was 20 years ago when a factory exploded next to a school in Italy, and the students, the teachers, horribly affected.
So, normal epidermis.
Normal epidermis.
Base. Or I guess straticorn.
Yeah, this one probably is better as a fellow case.
Okay. Good.
So if that's more towards normal,
There's definitely a very Well, that's kind of scar-like.
Kind of scar-like. The
Maybe
collagen
little
is certainly
hypercellular.
fine and ropey, a little hypercellular.
Maybe like NSF or
That's exactly what it is NSF. And this is bone formation in skin. And you have these elastic fibers sticking into the bone. So those are, usually they're round. These are kind of linear. So they're called lollipop bodies because you usually have this round osteoid and then the elastic fiber like a lollipop stick sitting into it. But in this case, you have a plate of bone with the elastic fibers sticking into it, and then the ropey collagen. This would be an increase in CD34 as opposed to the decrease that you see in Morphia. So fine ropey collagen, increase in CD34. When you do your CD34 stain, you'll see that the dendritic cells have long processes that tram track on either side of the elastic fibers. And when you have all of this osteoid with the elastic fibers sticking into it, that's pathognomonic for gadolinium exposure. That was Rob's paper that they don't always have NSF, but they always have gadolinium exposure. And you can also, this is your opportunity to say this is a bona fide example of gadolinium exposure.
Lollipop bodies of gadding.
Okay.
So maybe some follicular plugs, other dilated vessels, and there's some kind of maybe elastin, maybe a bramble bush vibe, or maybe not.
So maybe bramble bush. If it were bramble bush elastin, then you would think like penicillamine induced. In this case, what if I told you with a von Casa, all this basophilic stuff was calcified on the elastic fibers? PXE. In this case, you have perforating PXE, and this is periumbilical skin. So what would you expect? Would you expect angioid streaks in periumbilical perforating PXE?
No, maybe it's multiparous black female.
So usually an older black female who has calcification interstria, has had lots of kids, and doesn't have inherited PXE, which is probably what this is, if it's perforating PXE. Okay, so Paige, what do you see here?
So the epidermis looks fairly normal.
Yeah, in fact, everything looks pretty normal.
And then you go down here again, and you kind of have fascial.
Yeah, sitting right on top of the muscle. So this is probably.
Yeah, something like fasciatic.
And your differential?
Morphia Profunda.
Yep, and so you look for sclerosis higher up, not really seeing it. You could look for a CD34, and then the biggest thing is you just look for peripheral eosinophilia, because that helps, as a disease-defining characteristic.
Is that required for diagnosis?
I don't think it's 100%, but it's probably 99%. It's pretty good.
It's a very thin shave here, atrophic epidermis, a lot of hyperkeratosis, there's some dilated vessels.
So what's your differential?
So radiation dermatitis, lichen sclerosis, atropicus. Could be a morphia, but unlikely given a superficial shave. So
yeah, so morphia, very clever. So as a clinician, you probably would not take a superficial shave if you were thinking morphia. Mm-hmm. So more likely either LS or radiation dermatitis. The hyperkeratosis could be either, a little out of proportion to what you usually see in LS. The dilated vessels may be pushing you a little bit towards radiation dermatitis, but it's a superficial shave, so you don't see the presence or absence of a lymphoid band, present in LS, absent in radiation. You don't see loss of adnexal structures, you don't see radiation fibroblasts, you don't see radiation elastosis, just because of how superficial your biopsy is.
In that case, would the pigment incontinence be helpful?
You can get pigment incontinence in both of those, but
Okay.
usually not in morphia.
Okay.
Have a thickened epidermis with kind of it's like an ulceration.
So an ulceration, and what sits under that ulceration?
Is it fibrin?
A vertical column of fibrin, and what's flanking the fibrin on both sides?
It's like granulation tissue.
Granulation
So
tissue.
CNH.
So that is CNH, correct, which looks like any other decubitus ulcer. It's just a little baby one on the ear, because you hold the phone on that side, sleep on that side.
Okay, so this is a punch biopsy, squared off. You're showing me ectatic vessels,
Suggesting maybe the possibility of
radiation dermatitis.
radiation dermatitis. And tell me about the degree of cellularity.
It's really hypercellular.
It is really hypercellular. And tell me about the nuclei.
Really eccentric and larger.
Yeah. Do they look like radiation fibroblasts or worse?
Radiation fibroblasts are like nice little stellate things. These are
Yeah.
smudgy and not really, you can't find the borders of them very
And this
well.
is massively hypercellular with mitoses.
So something neoplastic.
Yeah. So this is unfortunately a post-radiation fibrosarcoma, where you still have your radiation dermatitis as well as your fibrosarc.
So we have a square biopsy with
Squared off punch suggests something sclerotic.
Mhm. There's really no adnexa there that I can see from this height.
Okay.
There's really not a lot of inflammation. There's no like papillary edema or anything. So I would think like morphia.
So probably morphia. It doesn't have the ectasia that you might expect in radiation dermatitis. Radiation dermatitis usually lacks deep lymphoid inflammation. This has nodular lymphoplasmacytic infiltrate at the dermal subq junction, which is characteristic of morphia. These are some dirty slides.
It's a little pale punch with some pigment. Look like ochronosis from this power.
Like ochronotic pigment. And in this case, you can really see that it deposits on the elastic fibers, and they're just starting to turn. And this was in someone who had dark, increasing darkening, where they had been using hydroquinone for years to try to lighten their skin.
So I've got squared off punch.
Squared off punch.
Looks like some pretty dense eosinophilic collagen.
Okay.
Little trapping of the
Trapping of adnexal structures. And tell me about this collagen versus that collagen.
The superficial collagen is a lighter pink, little less compact.
Yeah. So the smudging and widening and loss of space between collagen bundles tends to be deep. Morphia, superficial morphia exists, but 9 out of 10 cases of morphia starts at the dermal subq junction. So most cases of morphia are deep dermis. That's one of the things that helps.
So the epidermis looks alright. The
superficial dermis has some pallor to it, and underneath that there's a lichenoid band, so it's a lichenoid sclerosis.
Lichen sclerosis, absolutely. And how would that differ from morphia?
Morphia would not have the band.
Yeah, so morphia lacks the lymphoid band and has deeper smudging of the collagen, sometimes deep lymphoplasmacytic nodules at the dermal subcute junction, like other examples of morphia we've seen. How would this differ from radiation dermatitis?
Radiation dermatitis, there would be loss of the adnexal structures.
Loss of adnexal structures.
And there might be some ectatic vessels in the dermis.
Ectatic vessels high up. It also lacks the lymphoid band, which characterizes lichen sclerosis. May have radiation fibroblast, may have radiation elastosis. Okay. Yeah, there are some interesting things here. So I'm going to walk you through. First off, what do you see? Tell me what you see first off.
So, large tissue sample.
Yep.
You do have some dilated
So you have some dilated
superficial vessels with kind of the surrounding amorphous look.
Tell me about your fibroblasts.
Fibroblast.
Look almost like astrocytes.
Right, real large.
So huge gray stellate fibroblasts you usually associate with?
I feel like radiations, those are more slender.
Yeah, but these are just big radiation fibroblasts. So this is laryngeal tissue from someone who had throat cancer and was status post radiation for their throat cancer. So you're seeing the radiation change, not in skin, but in laryngeal tissue, but huge. This one was added to the teaching set because of the huge radiation fibroblasts.
They almost look like ganglion cells.
They do look like ganglion cells or astrocytes, something like that. And this one came in with a history of rule out Atrophiderma Pacini perini.
So not that, right? There's definitely, from what I can see, there's not like a loss of the dermis.
So Atrophiderma Pacini perini, what should it look like histologically?
The fat's really high up, right? And the dermis is thin. There's more loss of elast.
That's more acrodermatitis chronica atrophic. Atrophiderma Pacini perini, the atropho is kind of a misnomer. It looks like superficial morphia, basically. So in this case, I don't see a lot of smudging of fibers. CD34 showed complete loss in the upper half here. So sort of, I don't think you could make it on H&E.
You wrote the Blackheads, the Atroderma maroon in the same.
Do I put that in? Yeah, it probably is related. This one, we only have the elastic tissue, just showing preservation of the elastic. This is an acrodermatitis chronica atrophicans. We probably have an H&E slide of it in there. Let's see what else. Sometimes people separate them. Okay, how about this one?
Very thick punch.
Very thick punch.
Thickened dermis.
How about space between your collagen bundles?
Decreased.
Decreased. And how about
Some-
periadnexal fat?
Gone. Eccrine tracking as well. Some
And-
inflammatory infiltrate down deep.
So what do you think this is?
Morphia.
Morphia, very good. Okay, let's see. We have some different stuff in there.
There's a whole lot of LSM.
Yeah.
Two boxes.
We may need to pull out a different box and look. Okay, this is something a little different.
So it looks like a round, like dermal nodule almost.
Yeah, like a big nodule, and in the center you have the bubblegum collagen characteristic of keloid. So that is in
What is chronic graft-versus-host look like in this?
Oh, chronic sclerodermoid
Yeah,
GVH
'cause there's in the chapter.
can,
that's kind
can
of
look a
confusing.
lot like scleroderma or morphia.
Okay. Is there any way to differentiate it besides clinical history?
Clinical history, and clinically it tends to have a corrugated roof ripple pattern,
Okay.
which ordinary morphia doesn't have, and that's very characteristic for sclerodermoid GVH. You may still see some features of lichenoid GVH in the overlapping histologic. Those could be clues. Usually it's history, though. Okay. Let's get... could you see what Anita needs? Tell her I'll be down shortly. Okay. Let's go ahead. See what else we got here. Pretty normal, and then Shane, what do you have down here?
We have increased fiber septum there.
So you have thickening of the fiber septum, and what's that intensely staining stuff here? That fibrin, exactly. Something that takes up that much stain is fibrin. So fibrin deposition within a thickened septum or just above the fascia is probably, yeah. And in the acute phase, the fibrin is absolutely characteristic.
So we have kind of a perforating elastic thing going on here.
So perforating elastic thing, and is this a big wide ulcer like reactive perforating collagenesis?
No, I think it's probably the elastosis perforating serpiginous.
Exactly. And the EPS tends to be keratotic papules in a serpiginous array on the side of your neck, or retroauricular, and it's serpiginous histologically as well, and you see the altered elastic fibers being spit out. But Rob, the question may not be what's the diagnosis, but what's the association? So what things are associated with EPS?
Oh, so like mad pores or rap moped.
Okay, which stands for? So I picture a rat on a moped.
Right.
So go ahead.
So the R is. I'll take a little help. So Rothman Thompson, Acrogeria. P is progeria. Penicillamine, yes, and then Marfan's. Osteogenesis imperfecta. P is
xanthomoelasticum.
PXE. E is Ehrlich-Danlos, and then D is Down syndrome.
Down syndrome. So, I mean, it helps to have little mnemonics for things that show up. Oh, okay. Is there patient information involved? Yeah. Okay.
So I see some dermal pallor and
looks like maybe macular change.
Macular change, pigment incontinence, dermal pallor, hyperkeratosis. What are these cells here?
Some newts, or is it more lymphocyte?
Probably a sparse lymphoid band.
Okay, so LSNA.
So lichen sclerosis, very good.
Okay, no, let's just work on all the S and then
Okay. How about this one?
So this is again very squared off biopsy. Would be dermis thickened collagen, almost like scar-like collagen at the base.
So when you say scar-like, is scar-like usually hypocellular or hypercellular?
Hypocellular, this is hypercellular.
So this is hypo, and scar would be hyper with the fibroblast going east-west and vessels north-south.
More morphia.
So this looks like morphia, right? Except that the history here is post-bone marrow transplant. So, you know, this is sclerodermoid GVH, but I don't, honestly, there's no way to tell histologically. It looks just like morphia in this case. So you see some cases that you can see lichenoid GVH. There are other clues, but, you know, this one, it's purely history that tells you.
Yes, it's scleroderma. Chromatophores.
Okay. So, James, tell
Sure.
me about the difference between this side and that side.
There's a striking contrast between the elastin staining there.
So you have striking loss of elastic, and does it look like your dermis is scarred at all? Or is
No.
your collagen the same on both sides?
Collagen is the same.
So your collagen's the same, but only the elastic is gone on the one
We just
side.
have a focal elastic problem here, Dr. Elston.
And what would that focal elastic problem be?
Again, something like anetoderma.
Something like anetoderma.
Had that been more east-west, we could think about mid-dermal elastolysis.
That is correct. That would be your differential. So the difference between this and a scar is in scar, both the dermal collagen and the elastin have taken hits. And there's remodeling with fibroblast, east-west, vessels north-south. In this case, it is only the elastic fibers that have been nipped off, leaving the collagen completely intact. That would be anetoderma, or, as you said, if a broad middermal band, then middermal elastolysis. The acute phase, if you see it, is neutrophilic. The neutrophils come in and chew up those elastic fibers. And usually the patient has urticarial plaques, and then those turn into outpouchings where the urticarial plaque was in the inflammatory phase. Okay, Dan.
Do you then use neutrophil? What do you do?
Anti-neutrophil agents, absolutely. Because if you've seen people with anetoderma, I've seen it all over the face, and they look like horrible nodulous cystic acne, but it's just outpouchings of fat all over their face where they've lost the elastic focally. It's very difficult to manage surgically.
Yes.
And, you know, it's really disfiguring. And the patients hate it. They're willing to do anything.
The association with the association with antiphospholipids with antibodies, do you just ask history-wise if there's anything relevant, or do you check it?
I usually screen. I mean, anetoderma is rare enough that I usually do a full connective tissue workup. Many of them have lupus or some sort of smoldering connective tissue disease that's kind of underlying.
From this power, it has that CNH sort of feel.
Has a CNH feel. So tell me why a CNH feel.
Well, it looks like there's some granulation tissue on the edge.
So granulation tissue on both sides, flanking a column of
Looks like
fibrin, and then usually a little ulcer or break in the epidermis above that with a scale crust sitting above. So CNH. Okay, how about this one?
Looks like got some sort of kind of ulcerated
extrudiform
Good.
lesion.
Very good. So it is definitely extrudiform.
So I think this is probably it's broad-based, probably a reactive perforating flash.
Well said.
Let's put that in the next version.
Extrudiform. Right up there with ugliform cells and radiation dermatitis. Okay.
That's a classic.
Okay, so looks like some hyperkeratosis and maybe acanthotic epidermis. You go lower, the dermis seems a little bland, maybe. There's some, I don't know if it's like scar tissue maybe?
Yeah, that'd be the question. Is it scar tissue? In a scar, though, the collagen is usually oriented what direction?
East and west.
East-west. And these really aren't east-west. If anything, they're maybe north-south.
Mm-hmm.
It's definitely hypercellular. You have ropey collagen. So hypercellular, ropey collagen, renal failure, lots of imaging studies. Yeah, that's the nephrogenic systemic fibrosis, which is a horrible, horrible scleroderma-like illness brought on by the gadolinium exposure. Not something I would wish on anyone. Very debilitating disease.
Look like very focal, small channels, serpiginous, EPS.
So serpiginous channel with elastotic material being spit out through it, brightly eosinophilic elastotic, so EPS. I won't make you go through the associations again, but do them in your head.
Punch. So there's some large ectatic vessels. Epidermis is pretty atrophic, flattened.
So you have. Tell me about your superficial collagen.
Yeah, so it's kind of like really smudged and
Very
kind of
smudged. So this is lichen sclerosis, right?
So not with the ectatic vessels, probably.
So with the ectatic vessels, more likely
radiation dermatitis.
More likely radiation. Where's your lymphoid band?
Gone.
Gone. It's over in the case with lichen sclerosis, right? It's not in this one, which is radiation dermatitis. So you may have radiation elastosis, you may have radiation fibroblasts, you lack your lymphoid band, and you usually have ectasia of vessels. I think this is our last one because of time.
You have ulcer here, some
ulcer, and at the base of the ulcer, some fibrin.
some granulation tissue.
So what do you think?
C-negative.
Very good. Okay.
Yeah.
Let's go to work.
All right.